Okay, good. We are recording now. Welcome to Your Family's Mental Wellness. This is a program of the Institute for Marriage and Family Affairs, INFA for short. This program is designed to help you be in the know. One of the things that I do with families and those who are suffering from mental illness is education, to arm you with tools so that you can know what to do. This has become even more important now that we have grave shortage of mental health practitioners. They are in shortage. So the more you know, the better for you. Today, we're going to be talking about suicide. We will talk about it peripherally. If you're looking for a more in-depth study of this, a more in-depth skills and knowledge, wait till the end. I will be announcing a program that would help you get more knowledge. If you're suffering from suicidal ideation, from depression, anxiety, any of the mental health issues, you are better off knowing what to do. And then if you're also a caregiver, family member, or if you are a leader, you're a pastor, you are an overseer, you are a nonprofit organization leader, community leader, you have a lot of people who are looking up to you. You are a family head. These are knowledge that you need to have. It will come in handy. So at this time, I want to start by sharing a story that led us to this topic today, or focusing on this topic. So about 2 months ago in September, I walked into my office and I read the handoff notes, the tracker, we call it tracker. I read it and it told me about a patient who was admitted over the weekend. In the key word that I remember about that patient that was handed over to me was, he is isolative to self. It's a phrase, isolative to self, meaning that this person stays by himself and to himself, does not interact with anybody. And then they said he's always in his room. So when I went to see him, he wasn't the usual patient who are suffering from depression and anxiety. Usually they are lying down on their bed because they're tired. But this one was standing up and pacing around the room. He wasn't getting out of the room. He was just pacing from one end to the other. So I took interest in that. And I tried to engage him. He wouldn't say a whole lot. Would answer me yes, no, yes, no, yes, no. Wouldn't say more than that. So that was our introduction. But later on, I got to find out that this was a chief executive of an oil company who had worked in the oil industry for 25 years. He was nearing retirement. He was at the top of his career, doing very well until January this year. This was a grandfather. This was a husband. This is, not really was, but I use was because as at that time, I don't know what has happened. But through our interaction, we realized that he wasn't making any progress. He wasn't responding to therapy. He wasn't responding to medication, was not responding to anything. So when I engaged the family, we realized that he had not responded to anything for the last 6 months. I've been to several hospitals trying to find out what would work. Nothing has worked for him. It's been like that. The wife told me the story of what happened. He was doing well until January. His boss died of suicide. And then not only that, the responsibility of being the main person in the company landed on him. So the weight of that responsibility, the grief of the suddenness of the death, the whole thing threw him off balance. And that's when his journey started. But so I started engaging the wife and the children, and we did that for about a month before he was discharged. And at the end of it, the wife bought me a gift. He gave me a gift. He gave me this gift. And that's really why I'm telling the story. And the title of the book is The Suicide Solution. The Suicide Solution, written by Daniel Emina, E-M-I-N-A, and Rick Lawrence. I'm reading it now. I haven't had time to read it since it was given to me 2 months ago, but I'm reading it now and I'm finding it to be very, very helpful. They are not paying me, but I'm recommending it. So the wife of the man at the point of discharge gave me that gift and said, I want you to read and gain more knowledge so that as you have helped me, you can help other patients. And he wrote me perhaps one of the notes, the most beautiful notes that I've gotten from this career. And one of the things he said is, you have taken time to reach out to me and you have accepted all my frustrations without giving back any in return. This is something I have not experienced in the other 5 facilities that we have been through. So this warmed my heart that I had something to give, not material thing, but by just being present. So, and along the line, she had told me all their story. Then I realized that more than the patients that I see, there are stories behind the suicide ideation. There are stories behind the suicidal attempt. There are stories behind the suicidal, those that actually complete the process. There are stories behind them. Some of those stories are heart-wrenching. So from then I started thinking, we need to talk about suicide. And for the next 2-3 weeks, I know this is really not the time because of holidays, but that's what I'm led to talk about, suicide. So for the next 2-3 episodes, we're gonna talk about the risk factors. We're gonna talk about the symptoms. We're going to talk about how do you help someone who is dealing with suicidal ideation. Suicide ideation is the frequent thinking of suicide ending your life. It's not always that the person will say, I want to shoot myself, but just the feeling of ending it. One of the things my clients would always say, those who are careful, they know the implications of suicide, they would say, no, I haven't thought about killing my life, but I've wished I would just die, go to bed and not wake up. Those are signs of somebody who is having suicidal ideation, who is thinking about it. Now, there are 3 levels. 3 levels when you're thinking, and then when it has matured from just ideation, thinking, to plan. The person now has a plan. That elevates the suicide, the suicidality. From thinking, a lot of people think. The frequency of thinking of it takes you to ideation. And then when you now have a plan, and that's part of my assessment that I assess patients, have you thought about killing yourself? And we can ask that question up to 10 different ways and then get the results we are wanting. Then we ask, how frequently have you been doing that? How recently? If it's within the last 72 hours, obviously for us, it's a severe one. It's serious. We take it serious. But it's something that happened, oh, I thought about it 2 months ago. I'm no longer thinking about it. It's still an issue, but obviously the level of the severity is lower. So, and then do you have a plan? The plan that you have, do you have access to the plan? If someone says, I want to shoot myself, and they don't have a gun, they haven't bought a gun, they don't have money to buy a gun, they can't buy a gun, it's a plan, but it's a plan that is hard to achieve. But if that person owns a gun, they have a firearm, and they are thinking of using it, then that also elevates it, because it's a matter of impulse, and that's over. So those are assessment. I really don't want to talk about assessment today a whole lot. I want to talk about the risk factors, and there are a few of them that I will talk about. What are risk factors? These are things that make it likely that someone will consider, someone might attempt, or die by suicide. These are the risk factors that we use to examine ourselves, or examine our loved one, or examine our patient, our family members. Do they have that risk or tendency? Are they within that risk factor that might make them commit suicide? Suicide attempt and completion is difficult to predict. It's very hard to say 100% this person is likely to commit suicide, and they actually do that. It's difficult to predict, but knowing the risk factors help us a lot to minimize and be careful. I'll give you one example. If I know that you check out for 5 of these risk factors that I'm going to mention, I'm going to take you more serious in the way that I provide care and counsel and therapy and medication. If you check out on many of them, then obviously the elevation of care has to be there. We have to be particular about how we care. So what then are the risk factors? Number one, probably the biggest of them, is having mental disorder like mood disorders. Someone who is suffering from underlying mental illness. They have depression, they have anxiety, they have schizophrenia, they have certain personality disorders, they have bipolar. In other words, the person has a mental illness that's existing. That is a risk factor. That person needs to be assessed for suicidality. You have to have that in mind. If you are a practitioner, you have to think about that. If you are someone who is suffering from all this, you also have to take precautions of yourself. If you have a family member who has this, then that's a risk factor that you have to manage carefully. And then the second one is those who are dealing with substance disorder. In other words, they have alcoholism, they are addicts. They are addicts. In other words, they're suffering from drug addiction or alcoholism. That's a risk factor. And there are so many reasons for that. I can give you one because I'm also a substance counselor. One of the reasons is relapse. A lot of the frequency of relapse for those who are dealing with substance issues is very high. People are arguing it, but I subscribe to the fact that there is no cure for addiction and alcoholism. I believe that. I've seen it. I've seen clients who have gone to drug rehab 5 times, 6 times. I've seen it repeat over and over and over and over. Why? There's no cure. There is recovery. So when people maintain that recovery for a long time and they relapse, a lot of them give up and say, this has become my life, I might as well die. And patients can swear that they will never drink again or never use again. And suddenly they find themselves relapsing. Those are triggers for suicidality. Number 3 is feeling of hopelessness and helplessness. Those who have, these are symptoms of depression, obviously, but someone who feels that there is no hope, there is no help. I can't get out of this. This is me. Life is horrible. Just those kind of statements tend to lead to suicidality because there's really nothing to live for, according to that person. The person doesn't see any hope, anything to be alive for. They will tend to be the ones who will think, since there's nothing to live for, I might as well take my life instead of just staying here and suffering. So we've talked about those who have mental illness, talked about those who have addiction, talked about those who feel hopeless and helpless. The fourth one is those who are impulsive and aggressive, and those who have disease or disorders that have those symptoms. In other words, one of their symptoms is acting on impulse, just doing things and then regretting it down the line. That's a risk factor. And those who have aggressive tendencies, they tend to be aggressive in their behavior and impulsive in their thinking and decision making. That's a risk factor for suicidality. So if you're one who is always impulsive, you do things before you think about it. Especially those who jump into relationship quickly. They saw you today, they're marrying you next week. Or they saw you today, you're their best buddy in the next minute. Or they saw a car, they're not meaning to buy a car, suddenly they bought it. Making those impulsive decisions and aggressive tendencies, those are risk factors. History of trauma and abuse. That's probably the one that I see a lot in my patients. 80% of them have a history of trauma or abuse. Somebody did something to them when they were young. Someone did something to them somewhere. PTSDs, those who are suffering from post-traumatic disorder, they are a risk factor. Those who were abused sexually or physically as children, those who were abused as emotionally abused, any kind of abuse tends to be a risk factor. Those who have gone through domestic violence, those kind of things would be a risk factor for suicidality. Because why? Because the trauma and abuse kind of makes you feel less of yourself, less valuable. You begin to feel, I'm not worthy, I'm not deserving, I'm not worthy of love. And those kind of things lead to hopelessness and helplessness, and often is a risk factor for suicidality. And then the next one is major illness. They have cancer, terminal illness, illness that are chronic. It keeps coming. Every year it comes and it goes. And that tends to be also the same thing with mental illness. Those who are suffering from depression, you can't say it's cured, it's gone forever. Every year, every other year, you might have a bout. You might have an episode of depression, and you deal with it, you get better, you get back on your feet, and suddenly it creeps back in. Those are history of major illness, cancer, liver. Those are organ diseases that eventually the person is going to die from it. We're just managing to stay alive for now and for a bit. So previous suicide attempt, if in your assessment someone has attempted before and they did not succeed, that's a risk factor that you have to be mindful of. If you have a family member who attempted, did not succeed, they overdosed, it didn't kill them, they jumped through the window, miraculously they survived, we celebrate the survivor, the miracle of the survivor, but we also learn from it and take precaution. So someone who has a history of suicidal ideation, suicidal attempt, is going to be a risk factor. You have to be mindful of that. Family history of suicide. Somebody in the family has died of suicide. That points to somehow to genetics, may also point to a disorder that runs in the family, may point to how they do business, may point to a lot of things. But I had a patient last year who was twin. Her twin sister died of suicide, and she was in the hospital because she was thinking of also killing herself. So if you have a patient or a member whose family member had died of suicide, that's definitely a risk factor. What other minor risk factors do we have? Financial loss. Someone who used to be wealthy, now they are poor. Suddenly their money vanished. Poor business decision, poor economy. those kind of things, they go from riches to rag. It's usually the other way around. People go from rag to riches, but those who go from riches back to rag have risk factors are worthy of assessing for suicidality. Relationship is also one. Some of us can't handle breakup of relationships. Those who are going through divorce, those who are going through serious relationship breakup, especially if someone was betrayed. That's a risk factor. When the other one is also having access to things that can be used to affect suicide. You have a handgun, you have a firearm in the house, it's loaded, you're preparing it for the enemy, you might act on impulse. So having access to lethal means of self-harm is a risk factor. Now, when my patients are discharged, one of the things we have to ensure before they go home is that there is nothing like firearm in the house. And if there is, that it is secured where the patient does not have access to it. So the other thing we also have to take control of is the medication, the prescribed medicine that the patient is going home to. One of the things that people use mostly for suicidal attempts or suicide is overdosing, taking more of medication that is prescribed for their mental wellness, but they take more of it. So we are going to have to take that from the patient, give it to someone who is stable and caregiving, and they just dispense as needed. Now, what I recommend is, because of our busy life, bring out the daily dosage outside. The patient can take the daily dosage. Bring out 2 days, 3 days. 2 days, 3 days may not be little enough to kill, but to hand the person over the whole bottle of medicine, they are setting that person up for failure. So we have to take medication from our patient and keep it, and then give them a little. So having access to firearm, having access to medication, prescribed medication, having access to dangerous places. Some people plan to jump over the bridge. I see that a lot. Some people plan to use their vehicle and cause vehicular suicide. In other words, use their vehicle and run into trailer, run into something. That's the plan. So at the moment we begin to see that that person is impulsive, we may need to regulate access to vehicle, because that vehicle can be weaponized or can be used to perpetuate suicide. Local cluster of suicide. What does that mean? There are populations where suicide rate is very high. It could be neighborhood, could be race, it could be culture, it could be just community. But when you begin to hear a lot of suicide happening, more will happen, because those who are thinking about it will now hear about it and think more about it and then perfect it, what they've been nursing for a while. So a cluster of suicide increases the risk factor. So if you have depression and you're suffering, you're at that bad place where you're feeling hopeless and helpless, and you turn on the news or someone turns on the news and you hear that somebody ended their life, at that point you might think about it, why am I going through this? Why am I causing? And I hear that from my patients. It's not the pain that they are causing themselves. It's more of the inconvenience and burden that they are laying on their family members and caregivers. That's what weighs on them so much that they say, I need to end this and spare my family members, spare my wife, spare my husband from back and forth of going to hospital, from having to care for me. I'm useless, I'm not working, I'm not productive. All I am is problem to my family. I might as well end it. So just hearing other people are doing it gives ideas to those who may not have it, or affirms ideas to those who are thinking about it a little bit. So lack of social support and sense of isolation. That's the one that you can do. Lack of social support. one of the heightened attention or heightened risk factor that I consider is my patients that are being discharged and they live alone. They live by themselves, with themselves, for themselves. It's a risk factor. They are going to go to that lonely place. They've been in the hospital, they've seen people, they're seeing nurses, they're seeing therapists, they're seeing people every day. Now they go back to their one room or one house, empty room, empty house. Oftentimes, the time they left to go to the hospital, the house is in shambles because they've been sick for a while. They've not been grooming, they've not been cleaning anywhere. Piles of clothing, piles everywhere is dirty. And then when you discharge them, they're going back to the same place. So the first thing that they see is overwhelming. Where do I start? And then depression sets in immediately, and then the journey starts. So what do I do? Mostly encourage family members to go and stay with them for a while, if they have one. I encourage friends to stay, or encourage them to step down, go to stay with family members for a few days, get themselves acclimatized after hospital discharge, and then go back home, and then have frequent support person going to see them so that they don't slip back into depression. So these are the risk factors. There are many, many of them that I'm not going to go into because of our time. But these are things that tell us that this person is likely or may have a probability, not probability, a likelihood of engaging in this. Remember, the biggest of them is someone who has mental illness, especially those that are mood disorders. Their mood, their emotion goes up and down. Today they are high, tomorrow they are very low, up and down. Or those who are completely low, depression, anxiety, personality disorder, bipolar, schizophrenia. Those disorders that has been diagnosed is a huge risk factor that we have to monitor. And how do we monitor that? Obviously, if you're a professional, you have to do an assessment before you do anything. If you're not a professional and you don't know how to do assessment, engage your family member in a talk. Talk to them to find out where their mind is. What are they thinking? Are they thinking about tomorrow, or you're talking about next week's appointment and they are not keen into that? Those are indicators. And next week, I'm going to talk about signs and symptoms of suicidality. Signs and symptoms of suicidal ideation, suicidal tendencies. We will talk about what do you watch out. Now, these are the risk factors. We'll talk about what would you see when someone is actually thinking about it, thinking about taking their life. My time is up. My time is up. And at this time, I want to talk to us about the program we are running, the Certified Mental Health and Addiction Counseling Therapy Program. It's a 14 weeks program that the Institute of Marriage and Family Affairs runs. It starts January 15th. So if you have someone who is dealing with mental illness, what I am giving you is pep talk. This is not enough. You need to arm yourself with skills and knowledge to be able to do assessment, to be able to know what to do and how to respond to it. Obviously, if you're dealing with someone who is dealing with drug, a child who is suffering from drug addiction, a spouse who is suffering, a sibling who is suffering from it, these things don't go away by us punishing them or yelling or shouting or ignoring them. They don't go away. These are diseases that needs to be treated. You need to arm yourself with knowledge and skills to help that person navigate their way back to stability. That's what that course offers. That's one of our premium courses. The curriculum is tailored after the curriculum of drug and addiction training for the state of Texas. In fact, the materials we use is the same. So we train, we have opportunities for internship afterwards. If you are interested, leave us a message either on Facebook or reach us by email, info@timfa.org, TIMFA.org, or call me 281-701-7850. Text me. That would even be better. Look me up on WhatsApp. Reach out to us. We are enrolling now. That class starts January 15th. We have payment plan for you. 50,000 if you're in Nigeria, will get you in. I think if you're in South Africa, the round, how much? I think 1,000 something, 1,400 will get you in, or 2,800 will get you started. And then you have 5 months to pay the rest. But we are trying to be forearmed because we are now forewarned. Be prepared. Let's get ready. God bless you. We will now stop the broadcast. I will take about 10 minutes to ask